tonight's talk and subject matter is really about a subject that's becoming, at least for us, of increasing problems and awareness. And as we all know and about to hear, the incidence is clearly less than patients that have cervical myelopathy or degenerative lumbar stenosis. And the diagnosis can often be confusing and confounding because it can occur in the context of somebody that has concomitant cervical stenosis or lumbar stenosis. So hopefully after tonight, we can structure this case-based analysis to give everybody an overview of this problem. Ken, any thoughts?
No, I agree, Steve. It's an important topic, and one of the things that I want to mention, of course, is that often, I'll have patients coming to my office with gait instability or other myelopathic symptoms in their lower extremities, and they might come with just a lumbar MRI, or they'll come with a lumbar and a cervical MRI, and everybody forgets about the thoracic spine. And then I order a thoracic MRI and there's some big disc there or some other, form of pathology. So, I think it's just something that's important to have on everybody's minds because, like you said, it's not as common as other pathology.
Great. So Ahmed, if you can, our research coordinator is going to advance the next slides. So this is the faculty for our team, some of which are on and will be joining over the course of the next few minutes. Ahmed, if you can go to the next slide. These are our fellows that are going to be presenting tonight. And just from a brief agenda and overview perspective, Dr. Liu is going to be giving a 5-minute overview of thoracic myelopathy. And then Dr. Han will be presenting an interesting case on intradural tumors as a cause of thoracic myelopathy, followed by Dr. Stoll, who will be discussing sort of the more mundane and degenerative conditions that can cause significant neurologic sequelae of thoracic stenosis, as you'll see. And then we'll follow up with Dr. Lewis's more complex spinal problems in the context of thoracic myelopathy. And we'll give a few minutes in between cases so that we could discuss some of the salient features of each case. So with that said, Dr. Liu, if you can begin the discussion on just a brief overview of thoracic myelopathy.
Yeah, of course. So there is a paucity of data to describe the epidemiology of primary thoracic myelopathy in the general population. Most of our original descriptions of the pathology were reported in the context of associated musculoskeletal conditions such as achondroplasia that predisposes patients to thoracic spinal stenosis. The source of thoracic spinal stenosis can be from thoracic disc herniation, tumor, infection, and any of the listed conditions. Next. This figure is taken from a systematic review of the literature that investigated the relative frequency of the various sources of thoracic stenosis. It was interesting to see that ossification of ligamentum flavum was responsible for over 40% of the patient with thoracic stenosis. So let's review some of the common sources of pathology. Next. So large central or paracentral disc herniations, predominantly between T8 to T11, can compromise the spine's blood supply, and up to 42% are reported to be calcified. Infection and metastatic disease can also serve as a source of stenosis in the thoracic spine, either from direct compression or secondary to pathologic fracture. Staph aureus is a common pathogen associated with vertebral osteomyelitis, and metastatic disease is responsible for 90% of spinal tumor and can grow rapidly, resulting in neurologic deterioration. Next. So ossification of the posterior longitudinal ligament is commonly reported in patients with Japanese or Eastern Asian ancestry. The disease most commonly affects the upper thoracic regions. And the ossification of the ligamentum flavum is more prevalent in individuals of the Eastern Asian descent. Next. So compared to other regions of the spine, the thoracic core's tolerance for stenosis and manipulation during surgical management is considerably low. Understanding the source of stenosis and the relative anatomy of the thoracic spine are critical to developing a safe approach to treatment. So the microanatomy of the vessel supplying the spinal cord changes in the setting of compression, where the blood vessel becomes tortuous, thereby compromising blood supply. And the vascular compromise can occur with as little as 3 millimeters of spinal cord indentation laterally and 1 millimeter in the A to P direction. Next. So the thoracic core is sensitive compared to other regions of the spine for four main reasons. One, the disc extending into intradural space can directly damage the cord. It is compounded by thoracic kyphosis, and which also prevents posterior excursion, and the relative large diameter of the spinal cord to the canal. And as we just mentioned, the blood supply is tenuous. Next. Despite the challenges of the thoracic spine, its anatomy is benefited by the tremendous amount of stability. So some of its unique features, the rib articulation, some of the older literature even suggests that this confers a theoretical fourth column of stability. The facet joints are oriented vertically and are much more in the coronal plane. The thoracic discs themselves are considerably smaller relative to the surface area of the vertebral body compared to the other regions of the spine, which makes a large herniation far less likely just by nature of the reduced volume of the nucleus pulposus. Next. So in terms of clinical presentation of thoracic myelopathy, it is similar to the cervical myelopathy, with majority of the deterioration happening in a stepwise fashion. Next, please. So majority of the patients reported no upper extremity or neck pain. The most frequent complaint was lower limb numbness, with up to 50% of patients experiencing this as an initial complaint. And now we'll move on to the case reports.
All right, good evening, everybody. The first case I'd like to present is an interesting case. If you can go to the next slide, please. It's an 81-year-old lady who had a prior thoracic decompression and fusion in 2019 and 2020 for core compression due to presumed calcified disc. The patient had a surgery in 2019, never got better, and had to get another surgery in 2020, had an initial bit of an improvement, and came back to our clinic with more progressive lower extremity weakness, gait instability worsening over the past several months. Notably, specific for this case, the patient had a history of AFib on Eliquis with a pacemaker, precluding her from getting an MRI. The surgery that she had, the initial surgery in 2019, was a T3 corpectomy with a T1-5 decompression and fusion without any significant improvement, and had another T2 VCR and a cage insertion with the extension of fusion to C7, two pretty significant surgeries. Also complicated a hematoma washout a couple months later. Next. A physical exam patient is an alert patient who is able to walk with a walker, but came to our clinic in a wheelchair. She was full strength in the upper extremities, but her lower extremity had about a 4 out of 5 strength in the iliopsoas, otherwise full strength. Her sensation was intact, but she did have a 3+ patellar reflex and a positive clonus on the physical exam. Next. This was a 2019 July initial CT myelogram. If you can press the play button for us. This was before her original initial surgery. And this was, upon doing the CT myelogram, the original surgeons believed that this was a calcified disc that was protruding and indenting the thoracic core. And thus they went in and did a surgery. And next. And this was a CT myelogram that the patient had before present to our clinic with the corpectomy and the cage insertion. As you can see, that mass or the calcified disc per se was still present on that CT myelogram. And we had thought that there's a potential possibility that this could be an intradural mass, although we did not have an MRI to demonstrate the tumor. So we took her to the OR next. With opening the prior incision, we exposed all the old hardware, replaced any loose screws, took all the scar tissue away from the laminectomy site. At this point, we were able to use an intraoperative ultrasound that clearly demonstrated a large intradural calcified lesion. The dura is open, mass resected, and the frozen section came back as meningioma and was closing on the standard fashion. Next. And this was the intraoperative ultrasound that we got before we opened the dura. It's very clear that we can see an intradural mass compressing that thoracic cord significantly. Next. And this is an intraoperative picture with the microscope demonstrating the mass intradurally compressing the cord. Next. And this was a post resection. We were able to get a nice total resection of this mass. And next. And this was a post resection ultrasound, although with this, there's a lot of air inside the space where we took the tumor out. The ultrasound picture quality isn't as good as we get before the surgery occurred. Next. And postoperatively, the patient was doing well, neurologically intact, and discharged on post-op day 6. Came to our clinic 2 weeks later with significant improvement in walking, coordination, and denied any weakness. The final pathology came back as a grade 1 meningioma. Patient's pending a 6-week follow-up. Next. So I think in this case, an interesting discussion points is that when patients who are not able to get an MRI, what should we look for on a CT myelogram to indicate that the mass may be an intradural lesion? One thing that we can really focus on is that we don't see any displacement of dura toward the spinal cord, including the filling defects of that large lesion. However, I think it's still difficult to tell, and I think the best way is using this intraoperative ultrasound after laminectomy. And if we had used this back in 2019 after they had done the decompression and still saw the significant lesion in the ultrasound, we could have been able to prevent the patient from getting significant surgery, multiple surgeries, and perhaps be able to help that patient earlier. And then so basically using ultrasound after the resection decompression to ensure adequate cord decompression is, I think, a key point that we can take from this study as well, with this case as well. And that's the end of the case presentation, and opening up for any discussions.
Yeah,
Nathan, I'm sorry, go ahead, Steve.
That is an amazing case, guys. I mean, bravo. I know about this case, and I'm glad you guys brought this case up for discussion. So I know this is your case, Ken. Can you tell us a little bit about? I mean, Nathan brought up a lot of really great points with looking at the CT myelogram for looking at intradural lesions. But tell us a little bit more about the utility of using intraoperative ultrasound, for helping gauge your decompression and to sort of, I guess, rule out, as Nathan brought up, the thought process was a calcified disc herniation as the initial diagnosis as a cause of thoracic myelopathy versus this intradural calcified meningioma. So tell us, do you use it for everybody, Ken? When do you bring this tool out?
Right. So I use ultrasound for every single thoracic case that I do. Not only is it a good marker of whether or not I've adequately done a decompression, particularly for anything that's ventral, be it a tumor or a disc or et cetera. It also automatically confirms that you're at the appropriate level once you've done the laminectomy as well, because you can actually see the pathology. So even just a couple of days over the weekend, I did a big thoracic disc herniation. And as soon as we made a tiny little laminectomy, before we had done anything else, ultrasound, we could see that the disc was right there. And then, we then did the transpedicular decompression on one side, and we were able to get, what seemed like a lot of the disc out, but then we could see with the ultrasound, there was still a piece that was more medial. So then I was able to go back in and basically take out that other fragment, and then we could see that the cord was completely decompressed. So, unless, even in a case where there's dorsal compression, like, say, calcified ligamentum flavum or something like that, a lot of times there's a disc right at the same level, and you can't really tell, how much is being compressed dorsally versus ventrally. Then you remove the dorsal so in those cases, it's like, well, do you need to go in and do a decompression of the disc? You need to do a fusion at that point. And in those cases, you can take the pressure off dorsally, then look with the ultrasound, and a lot of times you'll see that the cord has floated back from the disc, especially down at the lower levels where the patient's not as kyphotic, such as T1112 and T1011, et cetera. So I think it's very helpful for that, and it allows me to determine whether or not the patient needs a fusion. For intradural tumors or intradural arachnoid cysts, et cetera, it also lets me know that I've gotten significant, enough above and below the tumor in terms of the laminectomy, so that I know I'm going to be able to have enough room to work and get the tumor out. So this was an interesting case because the meningioma was extremely calcified, even on the initial myelogram back in 2019. And the initial surgeon did the decompression, and she actually got better. And she got better because he was, by removing bone, was giving more room for the spinal cord. But then the tumor slowly grew, and then she developed symptoms again. So then the second surgeon, took away more bone, and she got better again because they were decompressing the outside of the dura. But then the tumor, started to grow again very slowly, and she became myelopathic again. So, I mean, it's just a very unusual case where she couldn't get an MRI scan because of her pacemaker, and the mass was just so calcified.
So, Ken, for those of us that try and stay outside of the dura, right?
Yeah.
Can you give us just sort of a little rundown of what the differential? There's a question from one audience member of intramedullary versus extramedullary. What's sort of the most common intramedullary intradural versus extramedullary intradural tumors that we need to know about? From
Sure. Sure. So extramedullary is certainly more common than intramedullary, and the two main tumors that we see intradural but extramedullary would be meningiomas and schwannomas. And usually you can tell the difference because meningioma is usually clearly pretty adherent to one of the sides. Sometimes there's a dural tail. Schwannomas maybe can look similar. Schwannomas can also sometimes exit through one of the foramen. But in general, the majority of these tumors are benign. Very rarely you can have metastasis, intradural, extramedullary masses, but by and large, schwannomas and neurofibromas, which are kind of tough to differentiate gross or on imaging, but then meningiomas as well. Intradural or intramedullary tumors are usually typically things like ependymomas and also astrocytomas. Ependymomas are usually a little bit more discrete, and that's a whole different ball game, and obviously can cause myelopathic symptoms as well, but that's a whole different ball game in terms of resecting those.
And do we need to rescreen these patients afterwards? Is there any consensus that you need to sort of get repeat MRIs, or in this case, I guess, repeat CT myelograms, or how do you guide that?
I mean, I follow all these patients for years, and so I will typically get. So I usually, for a benign tumor, I typically don't get an MRI immediately after surgery. I usually wait 3 months to allow all the postoperative swelling and changes to kind of go away. So I get their baseline MRI 3 months after, and then depending on what grade the tumor is. So like, for example, this was a grade 1 meningioma. We got the whole thing out. Obviously we didn't resect the dura, which would give an even better, amount of total cure for this type of tumor. But the likelihood of it coming back is very low. And since it was grade 1, then I'll get her post-op MRI in 3 months, and then I'll get another one in a year, and then I'll maybe get annual MRI scans for a few years, and then maybe once every 2 or 3 years after that. Because I have seen these cases where the patient had a tumor resection maybe 10, 15 years ago, were lost to follow-up, and then they had this huge recurrence, and then you're dealing with a much more challenging surgery to go back in once it's regrown to a significant amount of size many years later.
Got it. And how do you deal with the dura? I mean, usually if it's not adherent, you don't have to resect the dura. I would think that's a lot simpler to manage compared to somebody where you have to excise the dura. So how do you manage that in the context of meningiomas causing myelopathy?
So it's very rare that I've actually had to excise the dura for a spinal meningioma. Well, you can almost always peel it off the dura, and then whatever's left over, or wherever you see the attachments, you kind of just coagulate that area. So if there's any leftover tumor cells, you kill those tumor cells. Once I think the dura was so thin in one area that it caused a hole in that area, and then I sutured in a patch, which can be very challenging to do if it's all the way ventral. So for example, this meningioma was primarily attached to the ventral surface of the dura, but fortunately we were able to debulk it using an ultrasonic aspirator. And then we were able to separate it kind of systematically, coming in from the sides, from all the different sides, and kind of separating it from the dura.
Once again, for those of us that are orthopedically trained spine surgeons, is there any need, if we find an intradural meningioma, that we need to image the rest of the neural axis, the brain, or the cervical cord to look for any sort of skipped lesions, so to speak?
I think if you actually know that it is a meningioma, then you don't necessarily have to do that. The other tumor that I forgot to mention when we were talking about differentials would be an ependymoma, which we see more frequently down in the lumbar spine or up in the posterior fossa. Ependymomas are more likely to spread through the CSF. So those are in any patient where I'm suspicious that it could potentially be an ependymoma, so any lumbar intradural tumors, then I always image the entire neuroaxis in order to ensure that there's nothing else. But typically not. If I know it's a meningioma, the likelihood of there being another meningioma is probably pretty small. Schwannomas can be more frequent if they're multiple, especially if the patient has neurofibromatosis or other signs of neurofibromatosis. Then maybe I'd get imaging of the rest of the nervous system.
Excellent, great case, Nathan. Thank you. I think we're going to move on and to the next case. I think Dr. Stoll is going to present the next case. People feel free that are part of the webinar. It looks like there's a lot of people on, but feel free to use the chat room. Dr. Crandall and I can look at the questions that pop up and bring them up for discussion. So thanks for contributing your questions.
All right, thanks. That's quite the case to follow, but we'll see. Next slide. So this patient is a 79-year-old female who presented to clinic with progressively worsening bilateral lower extremity weakness over the previous 6 weeks. Her first neurologic deficit that she noticed was in her right leg, and then it progressed to her left leg, and then it progressed to the point that she needed a wheelchair to get around. She ultimately did end up developing bladder and then bowel incontinence. Her baseline status was she ambulated with a walker, and she lived in an assisted living facility prior to the onset of her symptoms, unrelated to her neurologic issues. So on exam, she did present to clinic in a wheelchair. She was unable to ambulate even with a walker in clinic. Her motor exam was 2 out of 5 in her lower extremity muscle groups with globally decreased sensation. She's known to have no reflexes at her knees or ankles, negative Babinski, no clonus. So next slide for the MRI. Oh, sorry. You could scroll that. So on her MRI, you can see that she has multi-level degenerative changes, but the most significant is the T10, T11. You can clearly see the thoracic disc herniation there that we've isolated. So next slide. She did have a history of lumbar stenosis as well as previous lumbar surgery. She had a previous laminectomy. Next slide. So the decision was made to proceed with a T9 to T12 laminectomy infusion, as well as a T11 transpedicular decompression to address her thoracic disc herniation. So surgery went well. These are the postoperative images from her clinic. She was discharged back to her assisted living facility on postoperative day 4 following her procedure. She was noted to have some initial improvement in her neurologic status on postoperative day 1, with some improvement in her left leg function. When she was seen in clinic, her neurologic status had improved to 3 out of 5 strength in both lower extremities. However, she said she felt her left leg felt stronger overall. Given that she was immobile at baseline for so long, we did obtain a preoperative ultrasound to evaluate for a DVT that was negative. And we also started her on Lovenox for DVT prophylaxis on postoperative day 2, given that we expected her to have a prolonged period of immobilization. Similar to the case that we just discussed, we also used ultrasound during the surgery to confirm that her cord was adequately decompressed. So, and this is the most recent follow-up. This case was done less than a month ago. So we just saw her back in clinic last week.
Yeah, Travis, thank you. That's sort of one of the more common, but also not necessarily common ways that patients are presenting to us in clinic with disc herniations, ossification over ligamentum flavum, facet hypertrophy, really isolated at that one level. Bunch of questions that I have, maybe JJ or Lou can chime in. A lot of these patients that present to us, with bad thoracic stenosis that's isolated, how do you guys decide when you're going to sort of stabilize? Obviously for somebody in their 80s that's neurologically impaired with some medical comorbidities, that's acutely declining neurologically, and previously very functional at an assisted living facility. How do you decide how big to go, right? Is it a decompression? Is it a decompression with a fusion? What are your thought processes? Maybe JJ, you can start with some of those thoughts, and Lou, you can add on.
So with these patients, something very important for me is how fast are they declining? Patients who are declining little by little, I think there's a lot less urgency. Patients who are declining rapidly, the endpoint is going to be very, very poor regardless. Now, depending on why they're declining, in these patients with increased thoracic kyphosis who may have PJK or something like that, I tend to, depending on their alignment, if their alignment is globally okay, I don't go that aggressive and then extend probably a couple more levels with a fusion. Now, if I know that, or there's other subtle findings where I stop 2 levels above and it's going to be just fine for a year, 6 months, and then they're going to have the problem again, I'd probably extend them a little bit more. That's a little bit of my decision process. Their global alignment, their bone quality, how fast the symptoms are progressing.
Lou, any thoughts to add on to JJ's?
Yeah, I agree with JJ. I'm probably a little bit more conservative. I just did one of these for a thoracic disc herniation, and I did a transpedicular approach, just one above and one below my transpedicular approach. In addition, she has that lumbar stenosis as well. And for, a debilitated older person, I think the right decision is to kind of tackle one at a time. The question that I have is, when do you do both? Is it always appropriate to do both at the same time in a young, healthy person? Or do you say, hey, we'll take care of the thoracic and then see what happens with your lumbar spine a little bit down the road?
Yeah, the decision, this was my case. This woman presented to me in clinic, with sort of a 6-week progressive decline, and the family wanted to be very aggressive, as you can imagine. There was no question that she needed a decompression urgently. The question to fuse or not to fuse, I think JJ brought up a lot of really good points. For me, her disc herniation was sort of incarcerated between the spinal canal and between the cord and the pedicle. And I drilled the whole pedicle out, took the facet joints out above and below. And that was the rationale for the fusion. The reason why I went a little longer was because her bone quality wasn't great. So that was the rationale. This is a complete obliquogram post-op, but the good news is she's doing a lot better. Travis brought up a really good point. When these patients present to clinic and are really sort of essentially bedridden or couch-ridden and really having challenges moving, I think it's really important to look for, DVTs prior to bringing them to the OR, right? So for these patients that are losing function, and are sort of at home chronically, and for whatever happened, either, not saying the family was ignoring them, but sort of trying to figure out what was going on and going from visit to visit as the patient's getting progressively worse and more immobile, risk for getting DVT and putting somebody on the table without studying them, can be potentially dangerous. So I think that's important. Luckily, she did not have a DVT, PE, or DVT. We didn't have to deal with that. But I guess Eugene's on, or Ken. Any thoughts of filtering these patients, or how do you manage somebody that has the same issue but may have a DVT concomitantly with their obvious need for neurologic decompression? Maybe Ken, any thoughts on that?
I think if you know that they have a DVT and they're on anticoagulation, then yeah, I would try to get them a filter and then take them off their anticoagulation prior to the surgery. But it also brings up a good point, because the thoracic disc that I did on Saturday was just diagnosed with a PE today. Didn't have a known DVT. But again, he was a guy that wasn't really walking well for a couple of weeks prior to surgery. So it's a good idea to just be on the lookout for that. I mean, he's doing fine. And now we're going to start him on anticoagulation post-op, a few days after surgery. But, it's definitely something to keep in mind.
Yeah. Any thoughts on the other concern I always have in the thoracic spine, especially with disc herniations, is getting the right level, and understanding that you're not fooling yourself into decompressing something that doesn't necessarily need to be decompressed. So I don't know if Eugene's on, or any thoughts, or any of the other panelists, any other thoughts on the best way to do that, the checks and balances that you use to ensure that we're at the right level.
Steve, it's Eugene. I worry definitely about the wrong level. And we've discussed about getting interventional radiology to place fiducials in thoracic spine, especially the upper thoracic spine where you can't count ribs. I will try to get a CT scan of the thoracic and lumbar spine to count from the sacrum and include the ribs. So if I need to judge it by the ribs, I'll know exactly how many lumbar vertebral bodies there are, as well as where the ribs start, and count up from there. I think Dr. Crandall points out to a great point of using the intraoperative ultrasound to confirm that you do have a thoracic disc herniation there. So it's a combination of using fiducials for the upper thoracic spine using CT guided, or at least CTs, and counting them from the ribs, as well as using intraoperative ultrasound. If they have prior hardware in there, whether it's an ACDF or lumbar spine, I think it's easy to kind of guide your count from those previous hardware.
Yeah, those are super great points, Eugene. Thanks for bringing that up. I think part of the value in the programs that are collaborative like ours and are combined like ours with neurosurgery is that they bring in new tricks of the trade and new pearls, and these enabling devices such as ultrasound have been around for a long time. And Ken and his team have introduced, and his partner Charlie Sansour have introduced the intraoperative ultrasound through the collaboration, and it is my new favorite tool. I really love it. I think it is phenomenal, some of the imaging you get and the satisfaction you get, ensuring you're at the right level, ensuring that your decompression is good. It really gives you sort of the ability to leave the OR knowing that that you've accomplished your surgical goals. I know Jens was going in and out and had his hand up. I don't know if he's still there. He had a comment. Hey, Jens.
Yes. No, hey, super program. Great cases. I don't want to keep you from the other cases. Very good points about the fiducials. I still think we need to absolutely know where and how many ribs there are. And so the CT should go to the lower C-spine and the upper lumbar spine. We should be aware of the unilateral kind of rudimentary ribs that can somehow throw things off. So CT for me is still the quintessential. We published on fiduciary markers and fiducial markers, and lo and behold, after the paper came out, we had one where the radiologist read and our read were one level off, and another one where the little gold pebble popped out and was in the soft tissue. So these are not fail-safe. So staying with the basics, having an AP image with the fluoroscope before you ever cut skin, so that you can correlate your preoperative, very careful rib count assessment with your intraoperative flora is important. We also use intraoperative ultrasound, but more often we use the intraoperative CT scan just to have that final level count, and then just either count from the top down or the bottom up, so you have a correlation. I found that to be very helpful. Great points, great talks. I'll sign off on that. Thank you.
Thanks, Jens. I mean, I think all super important pearls that everybody, has to keep in mind. Any other thoughts before we move on to the next case?
I have a different question for the whole panel. I have a patient who is coming with a very bad thoracic disc, but pretty much wheelchair bound, very old lady, a lot of comorbidities. When is it too late to even consider doing something?
Yeah, so I think what you're asking is, when do you say no, we can't help you, right?
Yes.
Ken, any thoughts? Is it ever too late if somebody is, so JJ, incomplete, like this woman, densely losing function over a 6-week period of time or longer? Or
it has been a lot longer than that. She's been pretty much wheelchair bound for the last year or so. And she does have some sensation, but clonus is pretty much a sustained clonus, Babinski, all the positive things for that. The neck does not look great either, but I think the biggest issue is coming from the thoracic spine. I'm get an MRI of the thoracic spine to obviously rule out anything that's going on, but very, very little function.
Does she still have bowel and bladder function?
And again, she's using a diaper, cognitively not great, but I think she still has function in bowel bladder.
I mean, if there's still function of bowel and bladder, I think you could potentially make the argument to try to do something to preserve it. But in those patients, I'm realistic with them, and I tell them, there's a chance that you could have this surgery and you may not get any better. And there's a possibility that they could have a complication or get worse. And ultimately, I leave it up to the patient. And, some of them choose not to have surgery. It just depends.
Yeah, for all these older patients, I've been always trying to bring in the family member. Mm-hmm. This lady came in with somebody from the nursing home who was on the phone all the time. So it's very hard to justify something. Again, let me see what it shows and I'll keep you guys posted, hopefully next meeting, but I'm not sure what it's going to show.
Yeah.
So just for clarification, we can just go around: no motor function in the legs, minimal sensory function over the course of, a progression over the course of, let's say, a week, so relatively quick. Rectal tone intact. You're decompressing, Ken? Sounds like you are.
In a week, yes.
Yeah. Eugene? Yes, no?
Yes, I'll decompress.
JJ?
In a week, absolutely yes.
Louis?
Yeah, for sure.
Yeah, so am I. We're fairly aggressive. So, all right. So let's move on. Let's move on to the last case, so we can sort of bring some perspective on something that's sort of a combined, complex issue. So I think Scott, you're up.
Yes, sir. Yeah. So I'm presenting this case that I had a part in. This is a 55-year-old male who presented to clinic chiefly with balance and gait issues, but really just complaining of low back pain. His past medical history is here. His past surgical history was notable for a lumbar decompression in 2015. He did better, or did well after this, rather. His social history is most notable for tobacco use. Next slide, please. So he was a telemedicine consult, again, for his low back pain, but did briefly mention upper and lower extremity coordination issues. And given this history and report, cervical and thoracic stenosis was a concern. MRI was ordered at that time, and then in-person evaluation was planned. About a month later, he came in for this imaging review. Next slide, please. On exam, had proximal bilateral upper extremity weakness, and then in the lowers also had some lower proximal weakness noted. His spinal alignment was good, but he was grossly unsteady on his feet and had a wide base gait. His Hoffman was positive bilaterally as well. Next slide. Initial radiographs, AP, lateral, and flexion extension views here showed multi-level degenerative changes. There was a spinalolisthesis at 3-4, C3-4. And then on the extension view, the patient reconstituted to a neutral alignment. Next slide. This was the cervical MRI we'll attempt to play here. So you see multi-level central stenosis as well as some foraminal stenosis. And then I call your eye to the C7, T1 level. There's a dorsal compressive lesion that maybe wasn't first appreciated when this patient presented, given the extent of their other disease and pathology. Next slide. So just for completeness sake here, the thoracic MRI distal to that really didn't offer any different story. The lumbar x-rays and MRI for the low back pain were suggestive of.
I'm just going to interrupt you for 1 sec. Can you go back to that MRI scan? I just want to get Ken's thoughts on that cervical MRI right there. If you stop right there, Ken, is there any suggestion, if you stop it right there, is there any suggestion that you can help us with understanding that sort of change in the caliper of the cord in the context of having these arachnoid? We know this is going to be an arachnoid web, but is there any clue to that on the MRI scan you can help us better understand, as opposed to the guy obviously has multi-level stenosis, as Scott alluded to with myelopathy, but in the context of this discussion and this cervical thoracic, problem and the, thoracic myelopathy, can you help us understand this MRI a little bit better?
So you mean what you're talking about at the cervical thoracic junction right there where the cord kind of becomes thinner?
Yeah.
Yeah. So, I mean, it looks, this is sort of what's called the scalpel sign, because it looks like a scalpel, the shape of a scalpel, but basically, it seems like there's something that's sort of displacing the spinal cord. And people call them arachnoid cysts, but a lot of times they're actually just kind of webs of arachnoid scar tissue that kind of encircle the spinal cord in that area. And it really becomes more or less a plumbing issue, because it basically obstructs the spinal fluid from flowing. And I actually have really good ultrasound video where you can actually see the pulsations coming in and hitting the arachnoid web and actually pushing down on the spinal cord with every heartbeat of the patient. which is really, when you see something like that, you truly understand why something like that develops myelopathy.
Yeah, Scott, I'm sorry. We just wanted to
Oh.
bring that up.
Yeah, no worries. Next slide, please. Go back one, please, Amit. So yeah, just for completeness sake, he had lumbar and an MRI of his X-ray, an MRI of his lumbar spine, and that just showed multi-level changes. Next slide, please. So he presented to clinic, had this exam and this history, and obviously the imaging. And so the concern was for more cervical myelopathy than thoracic, but the plan was for a C2 to T1 posterior decompression and cervical fusion. He presented to the operating room December of that year. Next slide, please. These were the immediate postoperative films, which show good hardware placement, no apparent issues. Next slide. The patient discharged post-op day 3 uneventfully, presented for his 4-week follow-up post-op, did well, was told to come back in 8 weeks, and then 7 months later presented to clinic with worsening neck pain, had a few falls over that 7 months, but no acute trauma, and most notably some persistent hand numbness, burning in the shoulders, and was still smoking. Next slide, please. These were his radiographs obtained at that time, and I think you see distal junctional kyphosis, hardware failure, pull out on one side and failure at the screw shank interface there, and the patient just had a tremendous amount of neck pain. Next slide. Given the somewhat peculiar nature of this, full-length scoliosis films were obtained to see if there was perhaps a distal spinal deformity driving this cervical thoracic issue, which there did not appear to be. Next slide. And then again, with this exam and this story, there was concern for residual pathology, and cross-sectional imaging was again repeated. Next slide. Here you see a CT post-operatively that shows good fusion in the upper cervical spine, but again, the distal junctional failure. No major issues related to hardware placement. And I mean, for time's sake, you can probably scroll through this one. Yeah, perfect. And then an MRI was repeated as well. And this one is hopefully a little bit more telling to kind of the points that Dr. Crandall alluded to, which you can really see that as so-called scalpel sign, the caliber narrowing, and then actually you can see some signal change to my eye here. Next slide, please. And again, this slide is just illustrative of that. Next slide. So given the concern for this, this case was discussed with our neurosurgical colleagues who felt this presentation as well as imaging were consistent with an arachnoid web. Surgical revision surgery was intended, and the patient was told he could not be smoking for this given the revision nature. And then in September of this year, on the 28th, it went back to the operating room. So these were the immediate post-operative films. So we didn't do much in the way of addressing having to change anything in the upper cervical spine, again, because there was good evidence of arthrodesis there. But more distally, we went to the thoracic floor vertebra, use these transition rods and an additional accessory rod. And then with the decompression, next slide, we're able to open up the thecal sac and remove the arachnoid web. Things went well. The surgery was atraumatic and looked quite slick, again, to people who don't typically go into the dura. But post-operatively, the patient started to report some right upper extremity and right lower extremity weakness. This was his exam post-op day 1 early in the morning. And so it had some pretty notable hand weakness as well as right lower extremity weakness that the patient was kind of distressed by. Next line or next. So as a result, we obtained additional imaging to evaluate the placement of our hardware. You'll see that on this CT, there's no unsafe hardware or issues that we can attribute to this exam. Scroll through the axials just for completeness sake. And then the next step, Amit will show is that we then obtained a cervical MRI. The MRI, you can see here, as a radiologist outlined, a T2 hyperintense lesion, more cranially to where we did our actual incision into the dura. And in discussion with our neurosurgical colleagues, this was felt to be indicative of a reperfusion injury. Next slide. So this was somewhat of a bump in the road for a seemingly smooth revision operation from our standpoint. But again, the patient was reassured that this should improve with time. For post-op day 3, the patient was improving with time. There was interval improvement, particularly in the grip and interosseous strength in the right hand, as well as the patient was ambulating independently again. And then on post-op day 17, just kind of given his overall picture, was approved and discharged to neuro rehab for further rehabilitation. And then I think, I can't remember if I have one more. Is there a?
That was the last one.
That was the last one. Okay. Yeah. So again, just the key points to take away from this is recognition of the caliber narrowing as well as the scalpel sign, and the pathology itself does exist. It's actually intriguing because in another clinic we had a similar presentation, more caudad in the actual thoracic spine, but an arachnoid web nonetheless. So this was something that I was less familiar with starting fellowship, and now I'm obviously intimately familiar with.
So was that arachnoid web resected at that primary surgery, or and recur, or incompletely resected, or why was it still there?
Jack, I think what happened, Jack, was the initial surgery was thought to be due to cervical stenosis and cervical myelopathy, and that's how the gentleman presented. And it was missed, and the patient had his myelopathy surgery, improving, because as Ken was sort of pointing out, the myelopathy, the cervical stenosis was decompressed. But then he presented back almost a year later with worsening pain and then paraparesis, and ripped out all of his hardware, had the distal junctional failure in the context of that a larger arachnoid web, or a more apparent arachnoid web. So, and it wasn't until the second surgery, Jack, that the distal junctional failure was addressed in addition to the arachnoid web.
Yeah, understand. Obviously he had like two pathologies coexisting. And, my eye first went to his multiple level stenosis as well. So, you can understand it, but that's a great case for people to see, because it's probably a 0 to 1 time in a lifetime for most of us.
Yeah. Ken, any thoughts on that from your perspective? When you get in there, you open the dura, and once again, for those of us that's trying to stay outside the dura, tell us a little bit about how you deal with it, what you see, how you deal with the adhesions typically.
First of all, I'll say that this is another plug to potentially consider using ultrasound, because maybe you would have seen the arachnoid web on ultrasound. But so typically, they're usually pretty straightforward cases, because you usually open up the dura and you usually see some sort of thickening of the arachnoid in there. The arachnoid usually surrounds kind of the inside of the fecal sac, but in this case, it's usually like a wall of arachnoid that sort of attaches to the spinal cord and is around the fecal sac. And you basically just do whatever you can to remove as much of it as possible with little micro scissors to cut it away and cut it off of the surface of the spinal cord. And then the other goal that I always try to do is make sure that there's communication of CSF between the dorsal spinal cord and the ventral spinal cord along the sides of the spinal cord as well. So if there's any arachnoid adhesions on the side of the spinal cord, I cut holes in them to make sure that the CSF is able to get from the front to the back as well.
Awesome. What are your thoughts on the reperfusion injury? Does that occur in our angst to push the map and maintain spinal cord perfusion, or
I don't really know, because I don't think we see it often enough, or at least I don't see it often enough to really know what causes it. I always have a conversation with patients about it before surgery, and I warn them about it, that sometimes you can get a little bit of worse before you get better for all sorts of various reasons, one of which, of course, is reperfusion injury. But this is interesting too, because it was several levels higher than where the arachnoid web was.
Yeah, it's fairly significant, as you know, and the patient woke up with sort of almost a hemiplegic. I mean, he had function, but his right arm and his right leg was fairly weak. Jens, you have some thoughts on this? I think you're on mute.
Trying to unmute, yeah. Great case. I'm not sure this is reperfusion trauma, because if I saw the MRI correctly, it was more in the posterior column. That doesn't make entirely sense. But maybe I misinterpreted that image. Yeah, going back to that MRI would be helpful. Yeah, this is posterior. I'm not sure what to think of that, because reperfusion injury would be anterolateral. So anterior spinal artery more. The big point for me is that when we do cord level surgery, we do a significant decompression, keeping the maps above 80, 85 preferably is very important. Having frequent motor checks and being very clear with the anesthesiologist that they need to keep on board with that to avoid just this phenomenon. The other and very controversial question is in certain high grade cord things. This is where I'd like to hear your thoughts, like in the thoracic cord, maybe preemptively giving steroids like even Nasca's 2-dose steroids, and being very careful as the lift off occurs to minimize the risk of this sudden rush or failure of blood flow and membrane instability, which then takes an escalating case. So MAPS high was my one suggestion. I'm not sure this is a reperfusion trauma, and doing some surgeries preemptively with steroids. This case is a great teaching case in many regards, and thank you for the scalpel sign. I've learned something, so thank you.
Anybody else? Any other questions or comments? All right, well, I mean, I think that was a wonderful discussion of cases that covered, pretty much 3 separate different causes of thoracic myelopathy, just to show that there's a diverse array of things that can lead to myelopathy in the thoracic spine, and that, it should always be in the back of someone's mind, especially if a patient comes to you without imaging of the thoracic spine, to consider getting it if they have symptoms that are potentially related to a thoracic localization. We talked about multiple things, such as the importance of intraoperative localization and making sure that you're at the right level, talking about ultrasound, talking about, good collaboration between orthopedics and neurosurgery, especially for some of these more complex intradural cases. But, I'd like to obviously thank all of the panelists and presenters, and of course the Seattle Science Foundation for making this possible.